Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will continue our speaking about the stomach lesions in infant and children. Previous lecture we speak about the first part, which includes the pyloric atresia and the pre-pyloric antral membrane and the congenital infantile hypertrophied pyloric stenosis. Today we will go to continue our speaking about the stomach lesions in infant and children, part 2. We will speak about the gastric volvulus, gastric perforation, gastric duplication cyst, and peptic ulcer disease, also microgastria, and finally foreign bodies and bezoar. Gastric volvulus. It is a very important subject related to the twisting or rotation of the stomach around one axis. This twisting or rotation may cause an acute abdomen in infant or a child, may present with severe respiratory distress, and may require intubation. So the first point is, what is gastric volvulus? Gastric volvulus defined as abnormal rotation of one part of the stomach around another. This rotation usually from about 180 degrees to 360 degrees. This rotation will lead to closed loop obstruction, closed loop between the upper end and the lower end of the stomach, with the content inside, maybe air, maybe gastric content, if the obstructions or the lower end of the twist involving the duodenum, the pancreatic secretions and the duodenal and the bile secretion will be present. So these closed loop obstructions may end with perforation, strangulation of this part of the intestine or of the gut, and finally perforation. However, if rotation of the stomach is less than 180 degrees, it is called gastric torsion. So we have two types of rotation of the stomach. We have gastric volvulus and gastric torsion. Volvulus means the rotation is from 180 to 360 degrees. However, torsion indicating that the rotation is less than 180 degrees. Gastric torsion may happen and may explain some attack of recurrent or repeated vomiting or transient vomiting in infant and neonate, and spontaneous resolution is usually the rule for the gastric torsion, unlike gastric volvulus. What are the risk factors for the gastric volvulus? What happened so that the stomach will twist or will rotate? What's the etiology or the risk factors for this pathology? Number one, diaphragmatic herniation. Diaphragmatic herniation is a risk factor for the development of gastric volvulus, whether paraesophageal or posterolateral defect, or even maybe Morgagni hernia, anterior defect. All types of diaphragmatic herniation predispose or act as a risk factor for the development of gastric volvulus. Moreover, diaphragmatic eventration. We mean by eventration, there is paralysis of one side of the diaphragm. So there is upward displacement of the stomach so they can rotate or twist around itself. The second risk factor is abnormal upper gastrointestinal anatomy. Infant and the children with malrotation, dextrogastria, previous upper gastrointestinal surgery, abnormal splenic anatomy. Sometimes the cause for the gastric volvulus is wandering spleen or asplenia syndrome. All these presentations, all these causes may predispose to gastric volvulus. What is the pathogenesis for the gastric volvulus? It is very important, and all of us know that stomach is fixed by 4 ligaments. This ligament is the gastrohepatic ligament, and the gastrosplenic, gastrocolic, and the gastrophrenic. This is the gastrohepatic ligament, and this is the gastrosplenic ligament, gastrophrenic, and the gastrocolic ligament. However, despite this ligamentous attachment, the stomach can rotate. It seems to be unlikely because this ligamentous attachment fixes the stomach in its position. However, we can observe that rotation of normal stomach may happen during endoscopic percutaneous gastrostomy placement. When we perform laparoscopic assisted percutaneous endoscopic gastrostomy placement, we observe that the stomach or normal stomach may rotate during air insufflation or after gastric distension. So despite this attachment, gastric volvulus may happen. The question now, when does gastric volvulus occur? Number one, deficient ligamentous attachment will allow rotation of the stomach. And we explain that normal stomach may rotate despite the presence of this ligament, as during laparoscopic assisted percutaneous endoscopic gastrostomy. So the stomach can rotate. So in a case of deficient ligamentous attachment, this may predispose to gastric volvulus. Number two, diaphragmatic defect, whether herniation or eventration, both condition. With or without deficient ligament, the explanation may be due to upward displacement of the transverse colon. You can imagine that the stomach is fixed and the transverse colon is below the stomach, and there is the gastrocolic. However, in some cases of the diaphragmatic defect, the transverse colon may be displaced up. This displacement may allow the stomach to rotate, leading to volvulus or gastric volvulus. The third cause may be gastric distension. Gastric distension may cause rotation of the stomach and may predispose to volvulus. This is very common and very well-known condition in what's called air swallowing in aerophagic neurologically impaired child. This type of children, neurologically impaired, can swallow large amount of air. In this type of population or this type of children, we observe more cases of the gastric volvulus. Also, abnormal band or adhesion may act as a lead point for the stomach to rotate around it. Congenital deficiency of the gastrocolic omentum. Maybe the congenital deficiency predisposes that the stomach can rotate and gastric volvulus may happen. In some cases of rectal atresia, with overdistension of the transverse colon, this may predispose to gastric volvulus. So it's very important to be clear that despite the ligament fixation of the stomach, normal stomach can rotate. On the other hand, if there is deficient ligament, the stomach will have more chance to rotate. Moreover, if there is abnormal anatomy, diaphragmatic defect, diaphragmatic eventration, may lead to the stomach to be intrathoracic and volvulus occur intrathoracic. Maybe gastric distension predisposed to the rotation. Presence of abnormal band, congenital deficiency, maybe any causes leading to distensions of the transverse colon. The most important item also is the post-operative gastric volvulus. However, it is rare complication. However, it is reported after some cases of Nissen fundoplication, especially if the stomach extensively mobilized by the division of the gastrosplenic, gastrocolic attachment. So if you remove this ligamentous attachment which fixes the stomach in its position, gastric volvulus may happen post-Nissen fundoplication. Also the same after tracheoesophageal fistula or esophageal atresia repair and diaphragmatic hernia repair. All these causes predispose to the occurrence of gastric volvulus, predispose to the increased mobility of the stomach, This increased mobility or abnormal mobility may cause the stomach to twist around itself. It's very important to know what are the types of gastric volvulus. Actually, we have two main types, and the third type is combination. The first type is known as organoaxial. From the name, it is rotation around the long axis of the stomach. Organo, related to the organ. So axial is the rotation. So rotation around the long axis, which starts from the esophagogastric junction to the pylorus. This represented by this blue line. So this is called the long axis for the stomach. So the stomach in such case will rotate around the long axis. So this is the first time, account for about 54% of cases. The stomach will rotate around the long axis of the stomach. Long axis starting from the esophagogastric junction to the pylorus. The second type is called mesenterico-axial gastric volvulus, 41%. Rotation around the short axis of the stomach. Where is the short axis? This is the blue line also. Transecting the greater curve and the lesser curve. So this line in the middle of the stomach, transecting the greater curve and the lesser curve. So you can imagine that the stomach may rotate around long axis or may flip on down or flip up around the short axis. You can imagine this is a picture after the volvulus. This is like twisting something, twisting around longitudinal axis. However, in such cases, there is flipping upward, up, down, or down, up. Flip of the stomach around the short axis of the stomach. We may have also combined volvulus, rotation around both axes simultaneously. Very important to understand these three types of rotation. Organoaxial, remember that organo related to the organ itself. So the rotation will be around the long axis of the stomach. Mesenterico-axial related to the short axis of the stomach, transverse line, cutting both greater and lesser curve. How to diagnose gastric volvulus? How to diagnose that this baby or newborn or infant or even a child may have gastric volvulus? Number one, the clinical presentation will depend on the degree of the rotation and obstruction. We said at the start that there is some form of the rotation called gastric torsion. And gastric torsions means rotation less than 180 degrees and mostly occur and may be related to intermittent vomiting in newborn or infant or even a child. And spontaneous resolution is the rule. However, if the volvulus occurred, we mean that rotation started from 180 to 360. The clinical presentation here will depend on the degree of this rotation and obstruction. The main presentation will be upper abdominal pain, distension, upper abdominal distension. However, take care that if the stomach is present intrathoracic, in some cases of diaphragmatic defect, some cases of paraesophageal hernia, and torsion occurred or gastric volvulus occurred in the thoracic or in the thorax, there will be no upper abdominal distension. Absent of the distension, if there is intrathoracic gastric volvulus. Number three, inability to pass the nasogastric tube due to presence of torsion. Torsion will obstruct the stomach, obstruct the upper end. So the nasogastric tube will arrest in the distal esophagus and it will not pass through the stomach. So this may be an indication for gastric volvulus. Maybe also hematemesis related to sloughing of the mucosa, related to bleeding from the gastric volvulus. The classic sign of gastric volvulus include, number one, arrest of the nasogastric tube in the distal esophagus. Because the twisted stomach or with gastric volvulus, there will be obstruction at the upper end of the stomach and the lower end. We named it as a closed loop obstruction. Number two, jaundice may happen if the volvulus involves the second part of the duodenum. Yes, volvulus can start from the upper end, esophagogastric junction, and extend down. So the end point will be the second part of the duodenum after the opening of the bile duct. In such cases, may be obstructive jaundice and the baby may be jaundiced. In neurologically impaired children, the presentation may be intermittent, chronic, non-specific. We say that it may be related to air swallowing in some types of neurologically impaired children. Also, this neurologically impaired child cannot explain very clearly what happened or cannot give an impression about the severity of pain. Very important radiological diagnosis. Plain abdominal and chest X-ray is very essential. You can look to this spherical gaseous palon or spherical gaseous swelling, large spherical gaseous gastric bubble. This is diagnostic for gastric volvulus. Plus, any abnormal anatomy seen in the plain X-ray, there is maybe hiatal anatomy. So there is a spherical gastric bubble with no distal gas if there is complete gastric outlet obstruction. So it is very important to know that the plain abdominal and chest X-ray is essential for diagnosis. Large spherical gaseous gastric bubble, number one. Number two, diaphragmatic hernia or eventuation or intrathoracic stomach may appear in the plain X-ray film. Gastric bubbles may be absent, yes, with nasogastric tube decompression. If you succeed to enter the nasogastric tube, or if the stomach is or the volvulus happened after nasogastric insertion, so there will be no gastric bubble. In some cases of the partial volvulus, it may be difficult to diagnose, especially if no associated diaphragmatic defect. Need high index of suspicion. Absence of the distal bowel gas is seen in the gastric volvulus, causing a gastric outlet obstruction. So in cases of the gastric outlet obstruction, you will not see any distal gas further in the intestinal loop. The second important radiological diagnosis is the upper gastrointestinal series. Very important. In organoaxial volvulus around the organ long axis, starting from the esophagogastric junction to the pylorus. In organoaxial volvulus, we will see greater curve of the stomach lies superior to the lesser curve. The greater curve will lie superior to the lesser curve. Also, the pylorus, which is pointed by the arrow, the pylorus will appear relatively in its normal position. However, very important to observe this, the greater curve of the stomach superior to the lesser curve of the stomach. So this displacement indicating that there is organoaxial volvulus with normal or relatively normal position of the pylorus. On the other hand, if there is mesenterico-axial volvulus, the first manifestation will be abnormal position of the pylorus. The pylorus will be lie high, overlap the fundus or overlap the gastroesophageal junction in the left upper abdomen due to rotation of the stomach around the short axis. We say that the stomach is flipped down or flipped up. So the pylorus will remain fixed and the stomach flipped over it, or the stomach flipped up, so the pylorus go up to lie over the gastroesophageal junction or to lie over the fundus of the stomach. Very important. You can differentiate very easy two types of volvulus. This type with relatively normal pylorus, greater curve above the lesser curve. However, in such case of the mesenterico-axial, the pylorus will lie abnormally high and there will be in the left upper abdomen due to rotation around the short axis of the stomach. This is very important, is the intrathoracic gastric volvulus. Intrathoracic gastric volvulus means there is displacement of the stomach in the thorax, maybe due to paraesophageal hernia, diaphragmatic defect, and after that, the stomach undergo volvulus or twisting. It is in the dye study, there will be upside down appearance of the stomach, as we see. Also very important, absent of the contrast material to the duodenum. Usually these types is obstructed with gastric outlet obstruction. The pylorus also will lie above the level of the gastroesophageal junction. So in intrathoracic gastric volvulus, there is maybe second cardiac shadow or second fluid level behind the cardiac shadow. These fluid levels or double fluid level or upside down appearance of the stomach with the absence of the contrast may help the pediatric surgeon to suspect that there is maybe intrathoracic gastric volvulus. Regarding the CT and the MRI, usually not necessary if the upper gastrointestinal contrast study performed, because all of us know that the CT require anesthesia, may require sedations in young infant. Also, radiation exposures will be very high. However, they give information about the structural abnormalities as a splenic position or absence of the spleen. These structural abnormalities may be the predisposing factors for the volvulus to occur. So they have an important point regarding CT and the MRI, give an information about the structural abnormalities. However, most commonly they are not used if the dye study is available and diagnose the problem. As we see, how to treat gastric volvulus. This picture demonstrates volvulus also for intrathoracic stomach. How to treat? Before how to treat, you must understand that untreated gastric volvulus may lead to ischemic necrosis, gastric perforation, or even death. So the matter is very important. So please take attention that you deal with serious condition. Infant may present with severe respiratory distress. May be related to overly distended abdomen, overly distended stomach, compressing on the diaphragm, making ventilation very difficult. May be related to severe pain, may be related to vomiting, may be related to sepsis. So this baby may present with severe respiratory distress. So the initial preoperative measures must include oxygen supply according to the demand, or ventilation. If the baby needs positive ventilations or ventilations must be included in the initial management. Volume and electrolyte replacement is mandatory. Nasogastric tube decompression. If possible, to pass a nasogastric tube to decompress the stomach, it's very good. However, avoid vigorous attempt or vigorous trial to pass the nasogastric tube to avoid risk of gastric perforation. So please try for nasogastric decompression if possible. It's okay. However, avoid vigorous trials because these vigorous trials is associated with high risk for gastric perforation. What are the basic principles for the surgical management of gastric volvulus? Very important. What are the basic principles? What you will doing in such cases, in such patient? Number one is the approach. We have two approaches, abdominal or thoracic approach. However, the abdominal approach is recommended in cases of gastric volvulus. Why? Because it also identifies the associated gastrointestinal anomalies. Number two, it allows for easy diaphragmatic repair and repair of associated anomalies. Wandering spleen, we can perform splenopexy. We can treat any band, remove any band causing the volvulus. So the abdominal approach is preferred than the thoracic approach, even if there is intrathoracic volvulus. Number two, it's very important to put in your consideration needle aspiration before manipulating tensely dilated stomach. In some cases, the stomach is very tense and very dilated. If you start to manipulate this, whether open or laparoscopic, the stomach will rupture and perforate. So please decompress this stomach with needle so you can manipulate it very safely without risk for perforation. Number 3, you must repair associated diaphragmatic defect if present. You must excise hernial sac, very important. Crural repair is very essential if there is paraesophageal hernia. Fixation of the stomach to the anterior abdominal wall, which is called gastropexy. Gastropexy. So the first is the approach. Number 2, related to the decompression of the tensely dilated stomach, repair of associated defect, excisions of the sac, crural repair, fixation of the stomach, or gastropexy. This is the main principles for the operative repair of the gastric volvulus. There is a debate about the gastrostomy alone. Gastrostomy alone can treat gastric volvulus or used for gastric fixation, especially in neonates. Plus, it provides adequate fixation, post-operative decompressions, and also route for post-operative feeding. So gastrostomy may be used as a line of treatment for gastric fixations in some neonates. Also, fundoplication. If there is evidence of the gross gastroesophageal reflux, fundoplication may treat volvulus, may fix the stomach and act as a prevention for volvulus. However, if there is no gross reflux symptoms, crural repair usually very sufficient in such babies, and there is no need for extensive surgery to perform fundoplication. Laparoscopic gastropexy, yes, recently used effectively in treating the neonates and children with or without associated splenic and diaphragmatic anomalies. Dealing by laparoscopy nowadays become more easy, so you can fix the spleen, remove the band, repair the diaphragm by the laparoscope with laparoscopic gastropexy. Also, splenopexy for wandering spleen is very essential if this wandering spleen is the cause for a gastric volvulus. We mean by splenopexy is to fix the spleen. We make an extra peritoneal pouch and leaving the space for the gastric vessels. This will fix the spleen in position. What are the complications associated with gastric volvulus? We speak that gastric volvulus is a very serious, may present with neonatal respiratory distress or sepsis or even death, may related to ischemic perforation of the stomach. So it's very important to know the complications. Number 1, prolonged ileus, gastric necrosis and perforation if neglected. Number 2, what's called ischemic sequelae. Ischemic sequelae may affect the lower esophageal, may lead to lower esophageal strictures, may lead to gastric outlet obstruction, may lead to microgastria, very small stomach, which may lead long-term gastrostomy or jejunostomy feeding, or finally need stomach substitution. So the problem need high index of suspicion. The problem can be corrected early, avoiding these sequelae or complications of delayed and neglected cases. Regarding the mortality, there is a high mortality in untreated gastric volvulus, reaching about or above 90% of cases, or 80% of cases, from subsequent gastric necrosis and perforation. With gastric perforation and necrosis, large of the huge amount of toxic materials and absorption into the systemic circulation, sepsis, multi-organ failure, plus the already present compression on the diaphragm, severe respiratory distress, and may lead to finally to death. So this is the first item today in the gastric volvulus, very important. The second problem or stomach lesion today is a gastric perforation. This is pictures with small gastric perforation like this. Gastric perforation. What is gastric perforation? It is a rare, life-threatening condition with significant morbidity and mortality. The etiology of the gastric perforation in the neonates or newborn is unclear. However, spontaneous or idiopathic perforation account for the majority of cases. What are the causes of the gastric perforation? Gastric perforations may be spontaneous perforation of the newborn or called idiopathic, which is a very common. Number two, may related to the perinatal stress, hypoxia, asphyxia, may related to the prematurity. This picture, baby with gastric perforation. Note the huge dilatation or the huge dilatation of the abdominal cavity by massive pneumoperitoneum. We will speak about it. Trauma, yes. Trauma may be related to nasogastric tube insertion, may be related to some endoscopic procedures in the stomach, may be related to any trauma leading to gastric perforation. Associated defects may predispose to perforation, like distal obstruction. If the baby with pyloric atresia, duodenal atresia, mid-gut volvulus, some cases of tracheoesophageal fistula, or congenital, very rare congenital deficiency of the gastric muscles, all these anatomical defects may be a risk factor and predispose to gastric perforation. Iatrogenic causes, not only the nasogastric tube, may be aggressive bag ventilation, maybe CBR and positive pressure ventilation may lead to gastric perforation. Also, perforation may happen during surgery. How to diagnose gastric perforation? Very important that history is very important in such cases. History may suspect iatrogenic perforation. There is recent intervention, recent trial for difficult nasogastric tube insertion, recent respiratory problem with CBR, with positive bag ventilations. So from history, you can suspect that there is maybe iatrogenic perforation, maybe traumatic perforation, maybe prior surgery, maybe non-steroidal drugs administrations. So history is very important to suspect the gastric perforation. Aggressive ventilation or cardiopulmonary resuscitation. The clinical presentations of the gastric perforation will be varied. Most neonates present within the first 7 days of life, however, later presentation also reported. Often the neonate is premature with history of asphyxia, hypoxia, feeding intolerance, or vomiting that may contain blood. This is the presentation. Very important, sudden onset of rapidly progressive abdominal distension. Sudden onset of rapidly progressive abdominal distension, tense, tender abdomen with signs of peritoneal irritation. Very important to put these items in consideration. Also, ventilation may be impaired or become ineffective with enlarging abdominal distension. So the setting of the ventilator needs to be elevated in this baby because the enlarging or overtly distended abdomen will compress the diaphragm and requiring higher ventilation, or the ventilation may become impaired or ineffective in this baby. Abdominal wall emphysema or pneumoscrotum also may be observed in such infant and newborn. Posterior perforation in the lesser sac usually present with more gradual course. So it may be difficult to diagnose because air or the perforation is trapped posteriorly inside the lesser sac, not affecting pneumoperitoneum or generalized pneumoperitoneum like the other perforations. Evidence of the underlying cause may be found at surgery. Yes, malrotation, congenital diaphragmatic hernia, tracheoesophageal fistula. This may be present during surgery. So the first items for the diagnosis is the clinical presentation. Take a good history. You can suspect together with rapidly progressive distension, tender, and the signs of the peritonitis. There is maybe emphysema of the abdominal wall or pneumoscrotum may be related to the perforation. The radiological diagnosis is very important and very essential. Please, there is perform a plain abdominal radiograph. You will see this picture. Massive pneumoperitoneum extend laterally and trapping the abdominal viscera medially, producing saddle bag appearance. Saddle we know that the saddle is related to the horse, is what's put on the horse before, on the back of the horse. Before you can ride over the horse, you put this saddle. So there will be saddlebag appearance. Massive pneumoperitoneum, extending laterally, trapping the abdominal viscera medially. Very characteristic X-ray of the gastric perforation. And in more cases, the stomach not be visualized. In some cases, we can see the rile outside the stomach. Also, this picture is the same. Can you imagine how it is more massive pneumoperitoneum compressing on the diaphragm, lead to ineffective ventilations, or may lead to severe respiratory distress, maybe cardiac arrest. This tight pneumoperitoneum will compress the inferior vena cava, prevent the venous return, will compress the aorta in this newborn and these neonates, and may lead to cardiac arrest and death. Stomach not visualized, subcutaneous emphysema, pneumoperitoneum, nasogastric tube outside the gastric limits. All these findings may be present. However, the most characteristic saddlebag appearance, massive pneumoperitoneum, extending laterally, compressing all the viscera medially. The dye study, if performed, will show extravasation of the dye from the stomach. However, the X-ray is usually sufficient for diagnosis, and the next step is exploration. Ultrasound may show ascites or fluid collections. What is the differential diagnosis of the gastric perforations? What are the differential diagnoses of gastric perforation? We can categorize the differential diagnosis in two main items. Number one, differential diagnosis of causes of sudden newborn deterioration. Very important. Maybe misleading with sudden newborn deterioration, because gastric perforation usually present with sudden newborn deterioration, ineffective ventilation, severe respiratory distress. Number two, causes of vomiting and abdominal distension. Sudden newborn deterioration, for example, pneumothorax, cardiac tamponade, cardiac dysfunction, intraventricular hemorrhage, electrolyte abnormalities, hypoglycemia, necrotizing enterocolitis, perforated other viscous, malrotation, midgut volvulus. These causes will cause sudden newborn deterioration. Number two, newborn vomiting and abdominal distension may be observed in some cases of intestinal atresia, Hirschsprung disease, meconium ileus, meconium plaque syndrome, imperforate anus, perforated viscous, necrotizing enterocolitis, and midgut volvulus. So what is the preoperative care for the infant with gastric perforation? Gastric perforation is a very serious disease. Gastric perforation, like gastric volvulus, if there is an emergency, intra-abdominal catastrophe, emergency pathology inside the abdomen. Infant with gastric volvulus may become unstable prior to the appearance of intraperitoneal air. Maybe infant may develop severe respiratory distress, requiring intubation and mechanical ventilation as the abdomen become more tense or overtly distended, compressing the diaphragm, preventing effective or adequate ventilation. Number three, broad-spectrum antibiotics must be initiated, fluid and blood for the hemodynamic stability and maintaining adequate urine output, nasogastric tube insertions with low intermittent functions to remove this air. Very important, aspirations of the overtly distended pneumoperitoneum. It is a life-saving procedure before surgical intervention, because the baby may die from these distensions. So with intravenous cannula, please aspirate this pneumoperitoneum to relax the abdomen. So aspiration of the overtly distended pneumoperitoneum, that impeding the ventilations and preventing effective ventilation, is life-saving, performed as life-saving as early maneuver or intervention, bedside, inside the incubators, or inside the ward before any attempt at surgical evacuation. What is the operative principles for the gastric perforation? Gastric perforations, you stabilize your baby, and intraoperative, you explore and found perforation like this one. Perforation in the stomach. What will you do? Traditionally, open exploration and repair is the rule, especially in the neonates and the newborn. However, recently, some trials of successful laparoscopic repairs have been reported. Open repair, number one, upper abdominal transverse incisions and the abdomen explored for the site of the perforation. However, if the perforation not found, you must perform careful exploration of the gastroesophageal junction, of the duodenum, of the small bowel, of the colon to search for the source of this pneumoperitoneum, search for the source of this perforation. Number four, lesser sac. Don't forget the lesser sac. Must open the lesser sac and inspect for the contamination or perforation in the posterior gastric wall. If there is isolated perforation, you found an isolated perforations, the devitalized edge are debride and until you reach viable tissues, then close in 1 or 2 layers and may be reinforced with omental patch if needed. This is for isolated perforation. In case of extensive perforation or necrosis, these children or this infant or newborn requires usually subtotal or total gastrectomy. It will depend on the situation of the baby. If the infant is stable, you can perform subtotal gastrectomy with reconstruction using esophagogastric anastomosis. Following the perforation repair, abdominal lavage performed with warm saline. Post-operatively continued supportive and resuscitative care should be continued with broad-spectrum antibiotic, gastric acid suppressions, total parenteral nutrition, and nasogastric tube insertion. Feeding also is stopped until the baby is stabilized. So we speak about 2 important items, gastric volvulus and gastric perforation. Now we will shift to the third pathology related to the stomach in infant and newborn, which is called gastric duplications. Duplications from the name means double, something double, 2 things. Yes, duplication related to the stomach. It may affect any part of the GIT. However, our talk today related to the gastric, the stomach duplication. Second part, embryologically abnormal related to the developing stomach, commonly related to the greater curve, swelling or maybe cystic or maybe tubular structures, maybe communicate with the lumen of the stomach or not communicating with its lumen. Let's see. What is gastric duplication? It is a congenital, cystic, or tubular malformation found adjacent to the stomach, sharing a common wall with the stomach, characterized by the well-defined coat of the smooth muscle and the epithelial lining consisting of some type of GIT mucosa. As we see, this is the stomach and this is the cyst. Also, there is clear that there is cystic lesions related to the wall of the stomach. Usually may be asymptomatic, discovered incidentally on physical examination or unrelated imaging, something related to the stomach, or appear in the dye study as cystic swelling related to the stomach. Sometimes a newborn or the baby present with vomiting, poor feeding, or epigastric mass. What is the pathology? Most duplications are located close to the greater curve of the stomach or the pyloric region, and the cystic varieties are the most common. If this duplicated part communicate with the gastric lumen, the patient may present with hematemesis or melena, because the acids in the stomach will affect the mucosa of the duplicated part, because this duplicated part mucosa is not accustomed for the HCl or the acids of the stomach. So there is maybe hematemesis or melena. Very occasionally, this duplicated cyst may communicate with the pancreatic duct, which carry an important criteria that during removal, not to injure the normal pancreas, which is very important. What is the clinical presentation? Number one, asymptomatic abdominal mass or abdominal swelling. No symptoms. Maybe vomiting or bleeding. related to the presence of the communicating cystic swelling or compression. If this duplication near to the pylorus, it may compress the pylorus, giving the same presentation as infantile hypertrophic pyloric stenosis. However, differentiation by ultrasound will be straightforward, as we explained last lecture. Rarely present with perforation of the duplicated part. So this is 4 main clinical presentations of the gastric duplication cyst or tubular structures. What is the treatment? If non-communicating gastric duplication cyst, complete excision and resection of the shared wall to avoid the complication, obstruction, torsion, perforation, or hemorrhage. In such image, this is the stomach, and this is the duplicated part. This is the duplications and intraoperative excisions or removal of this duplicated part. Communicating gastric duplication cyst requires no intervention when both lumens are patent. If both lumens are patent, no symptomatology, we may perform no intervention. Drainage and marsupializations of the cyst reported. However, marsupialization of the stomach into the stomach exposes the unprotected mucosa of the cyst to the gastric content with risk of ulceration. We said that the mucosa in the duplicated part is different from the gastric mucosa, not accustomed to tolerate the HCl. So this exposure may lead to the risk of ulceration inside the duplicated part, perforation of the duplicated part, baby may present with bleeding or something like this. Also, there is some trials of the drainage procedure like cystojejunostomy to anastomose the cyst with the jejunum, may be complicated by stenosis of the anastomosis or blind root formation. The final option is leaving the cyst in place. However, it is not wise because for the potential for malignant transformation in this duplicated part or in the mucosa of this duplicated part. So the rule is excision of the duplicated part and the common wall. Very important to excise and remove this duplicated part, which is related to the gastric duplication cyst. Excision of the gastric duplication, yes, associated with pancreatic ductal abnormalities may injure the normal pancreas. Very important to observe that the duplicated part not communicating with the pancreas or pancreatic duct. As it has been reported that some cases there is communication between the duplication and the pancreatic duct with pancreatic ductal abnormalities. In such cases, you can injure or you may injure the normal pancreas. Now we will speak about another pathology which is called microgastria. From the name, micro means small, gastria means stomach. Microgastria. What's microgastria? Very small, underdeveloped stomach. May be related to abnormalities in the foregut development, not developed, dilatation not happened, elongation not happened in the foregut. So it is called microgastria. The spectrum of the condition may extend to what's called agastria, complete absence of the stomach, no stomach. Associated anomalies with microgastria, usually bacterial association. All of us know the bacterial association, and the only treatment will be jejunal feeding tubes as a temporary measures to gain weight or to save the life of the baby. However, the only described is a gastric augmentation, Hunt-Lawrence gastric augmentation. It is a gastric augmentation to create a large gastric reservoir by double lumen Roux-en-Y jejunal pouch. As we see, this is double lumen Roux-en-Y jejunal pouch anastomosed to the microstomach, and the continuity of the GIT is performed through the other limb of the Roux-en-Y. So the idea is to bring 2 lumens or 2 loops and to open it, the septum in between them, to make a large reservoir simulating the stomach, anastomosing this to the presence microstomach. However, these operations associated with many complications, for example, dumping syndrome and maybe sometimes other complications. However, it is the only solution present up till now, beside the temporally jejunal feeding and the jejunostomy tubes for feeding. The next items will be related to peptic ulcer disease and its complications in infant, children's, or pediatric cases. Peptic ulcer is rarely seen in children. However, some report of pediatric bleeding ulcer, perforated ulcer, gastric outlet obstructions due to peptic ulcer is reported in children. Peptic ulcer usually associated with Helicobacter pylori in most pediatric cases. The treatment will be directed to acid reduction, eradication of the Helicobacter pylori. Also, the triple therapy, well-known proton pump, amoxicillin, clarimycins, typically used initially. Operative treatment indicated in the complicated peptic ulcer cases, whether there is perforation or gastric outlet obstructions, or maybe laparoscopic or open exploration. Gastric resections usually not needed, since the development of the effective proton pump inhibitors to treat these ulcers. The last items related to the foreign bodies and the bezoar. Foreign bodies, gastric foreign bodies, can be generally ignored. If the foreign body, there is a general rule that if the foreign body can pass the esophagus and the cricopharyngeal muscle, it would pass likely out from the rectum. Even the sharp object usually pass safely, no problem. However, the only exceptions is the bottom vitreous, which have a large incidence of leakage and should be removed if they have not passed through the pylorus. Otherwise, and other types, watchful waiting is a reasonable strategy. Occasionally, also large coins can remain in the stomach, presenting with intermittent gastric outlet obstruction. In such cases, it is reasonable to remove these objects. Most foreign bodies nowadays removed endoscopically by the snare, grasper, or bag using what's called overtube. Overtube used to extract the sharp object that may cause injury of the esophagus upon removal. Bezoar, uncommon cause of the gastric outlet obstructions associated with chronic abdominal pain in children, may be phytobezoar, indigestible food particles, or maybe trichobezoar related to swallowed air, commonly in some cases of the social disturbance and especially in female. May be referred to syndrome, Robinzel syndrome, associated with some females taking the habits of swallowing and eating hair. Hair usually fills the stomach and makes sense to the duodenum, and the trial of endoscopic removal usually ineffective, except in a small bezoar. Dye study will show the filling defect representing the hair present in the stomach. Bezoar typically removed by the gastrostomy at laparotomy. However, laparoscopic removal also reported. Recently, large gastric trichobezoar removed laparoscopically with endoscopic bag or placement of the board into the stomach with removal through this port. Also, laparoscopic assisted removal with wound protector is reported. Thank you very much for your attention. At the end, we can conclude that gastric lesions in newborn and infant is very important. We may have different varieties of injuries related to gastric outlet obstruction, including the infantile hypertrophic pyloric obstructions, which is very important cause for gastric outlet obstruction, related to the pyloric atresia, maybe related to the pre-pyloric antral diaphragm or web. Gastric volvulus is a surgical emergency of the newborn, may lead to severe or sudden deterioration of the infant. Gastric perforation may present with tense abdomen, may impair the ventilation, respiration, may be associated with high mortality and morbidity. Gastric duplication may cause bleeding or vomiting related to these duplicated parts. These duplicated parts may be associated with the pancreatic duct structural abnormalities. Maybe microgastria. These children may have associated anomalies. Usually, their fate and sequelae is complicated due to very small gastric reservoir, gastric pouch. And finally, the foreign bodies and the bezoar in the stomach. So the subject of the stomach lesions in the infant and newborn is very important. and you must understand all the items of this subject, starting from the gastric outlet obstruction, ending with foreign bodies and bezoar. I think the two lectures is very important to put together and to understand the pathology described in each disease separately, the clinical presentation, the symptom and signs, and the radiological diagnosis. All diseases need high index of suspicion, need the pediatric surgeon to be alert to these diseases. You can suspect, differentiate, interfere. There is life-saving procedures. In some special cases, you must be oriented with these life-saving procedures. Plain X-ray abdomen and chest is of ultimate importance in the diagnosis of many of these diseases. Ultrasound is of superior importance in diagnosis of pyloric obstructions and other causes. The sophisticated investigation like CT and MRI usually reserved for special situations and special cases. Thank you very much for your attention, and see you next subject of pediatric surgery mid-east. Thank you very much.